Hello, and we're ready to get started on our discussions of antidepressants. This is, of course, an important topic because so many Americans and people worldwide take an antidepressant every day. So I think it's important we spend some time talking about depression and the different classes of antidepressants. Today we're going to talk about depression, a little bit about what depression is, how we differentiate it from other disorders, talk about what causes depression, or at least what we think causes depression, what we call the pathophysiology of depression, and then do a little bit of discussion of the evolution of antidepressant therapy and the use of antidepressants. We'll then, in later lectures, go into the actual drugs themselves, talk about different classes of antidepressants and their issues. So let's start off with a quick overview of what depression is. About 4.5% of the total worldwide burden of disease and disability-adjusted life years is associated with depression. So it's a pretty significant chunk of disease-related disability is related to depression. It's responsible for up to 70% of psychiatric hospitalizations, and 40% of suicides are associated with those diagnosed with major depressive disorder. About 9 to 10% of the U.S. population suffers from a major depressive episode each year. 10% of men and 25% of women will experience depression in their lifetime. It's important to understand that while there are gender differences in the diagnosis of depression, it's not always clear whether or not that is gender differences in diagnosis or an actual gender difference in the occurrence of depression. It's important to keep that in mind. Now, there are some reasons to think there might be gender differences in the occurrence of depression, but we will discuss those sort of as we move along. So keep that in mind. Understand, however, women are at greater risk for attempting suicide. Men are at much greater risk for actually succeeding in suicide. And the reason for that is men tend to use a firearm. And that obviously has a much more lethal component. We're not going to spend much time talking about suicide. There are other courses which will cover that, but it's important to understand that it's potentially a risk associated with depression and certainly a risk sometimes associated with drug use. So keep that in mind as we move along. Depression is one of the most undertreated diseases in the medical literature. About 21% of yearly cases are adequately treated. The reasons for that are varied. Of course, some people don't want to go on medication. Some people don't want to admit to being depressed. There are obviously a variety of reasons why people might not get adequately treated. But it's important that we understand what depression is and where it comes from, and certainly understand why this really is a disease. This isn't somebody who's just down. This isn't somebody who's lazy. This is a genuine biological condition that requires treatment. So what really is depression? Well, it's 3 times more common in first-degree relatives of people who have depression than in the general population. So what that tells us is there is likely some sort of genetic component to risk for depression. We know stress is a part of depression, and we're going to talk about that here in a bit. So it might be those relatives also experience stress, or they might be responding differently to stress. And there is evidence that there is a genetic component to how we respond to stressful situations. There is a high, what we call comorbidity with depression. That is, it's often associated along with other disorders, and we're going to talk about this in a variety of circumstances. About 84% of people with major depressive disorder have at least one comorbid condition. 61% had a concomitant axis 1 disorder. 30% had an axis 2 diagnosis. And 58% had a comorbid axis 3 illness. And these are different parts of the DSM-4. I'm not going to ask you about these on the exam because the DSM is changing to the DSM-5 and these axes are changing. But keep in mind, those of you who are familiar with the DSM or want to look it up, these have to do with physical disorders, personality disorders, as well as other actual psychological disorders. So without getting into too much detail about those axes, because again, those are going to change, keep in mind that people with depression often have other issues going on. So, depression is an affective disorder, which means it's a disruption in mood and emotion. So it's characterized by alterations of emotion or mood. Diagnosis of major depressive disorder will occur if 5 of these following conditions are present daily or almost daily for at least 2 weeks. Depressed or irritable mood, decreased interest in pleasurable activities and ability to experience pleasure, significant weight gain or weight loss, insomnia or hypersomnia, that is, people can't sleep or do nothing but sleep, psychomotor agitation or psychomotor retardation, which just simply means they're agitated, moving around a lot, or just simply won't move at all. Things are just disrupted. Fatigue or loss of energy is clearly associated with depression, and that's probably the easiest identifiable symbol. Certainly feelings of worthlessness or excessive guilt can be associated with depression. Diminished ability to think or concentrate. Now, this is an important part of depression because we now understand that part of the pathophysiology of depression is related to brain structures associated with memory and cognition. And we're going to talk about that here in a bit, but diminished ability to think or concentrate is certainly an important component of depression. In fact, it's probably one of the best ways to diagnose depression in people who oftentimes don't understand the depression in themselves. And finally, of course, recurrent thoughts of death or suicide, and this is obviously the most significant component of depression that we want to try to make sure if anyone's having these thoughts that they do get some help and can get into treatment. And treatment doesn't require much beyond talking to somebody and seeing whether or not if antidepressant therapy might be for that person. So one of the important things we have to do when talking about depression is do what we call a differential diagnosis, and that is we have to differentiate it from other disorders that might be associated with depression or with depressive-like symptoms. So again, I don't want to spend a lot of time on this as the DSM-5 is just coming out, but we do have to think about the fact that there are mood disorders. In fact, we have major depressive disorder, which can be single or recurrent, with or without what we call melancholia. These are people who feel very sad and melancholic and very depressed. Sometimes this can have a seasonal pattern. We've talked about what's called seasonal affective disorder, which is associated with the amount of sunlight that we're exposed to. There seems to be some connection between vitamin D and sunlight and mood. Certainly, a number of people around here, I think, experience seasonal affective disorder. Certainly when we have a longer winter, people start to get irritable and unhappy. We're going to talk later about bipolar disorder. Now, depression is a part of bipolar disorder, and so it's important to make sure that we're talking about depression and not just part of somebody who has bipolar disorder. So these people will be depressed, but they will have mixed times between depression and what we call mania. And so it's important to make sure we get a differential diagnosis there. Cyclosmic disorder is like bipolar, but not as severe. And dysthymia is a less severe type of depression, but tends to be much longer lasting. It tends to last 2 years or longer. And so dysthymia is a very long-term, lighter version of depression. A major depressive disorder is very debilitating, whereas dysthymia is less debilitating but longer term, and can certainly lead to a major depressive disorder. The other things we want to differentially diagnose depression from are psychotic disorders. So we want to make sure there isn't some underlying psychosis that's resulting in depressive symptoms. Some other mood disorder due to a general medical condition. So, for example, it's not uncommon for someone who's diagnosed with a major illness, cancer, HIV, to go through a period of general depression. It's important that depression still get treated because it's just as important as their other conditions. And so make sure that there's some support there. And then finally, there can be substance-induced mood disorder. And we're going to talk more about this when we get to certain substances. But for example, people withdrawing from cocaine or amphetamines can go through a mood disorder or a disruption in their mood. So we want to make sure that we think about and treat that as well. The next place I want to turn is thinking about what causes depression, or what we call the pathophysiology of depression. So where is this happening in the brain, and how is this happening? Because we know this is a brain disorder. This isn't, again, just people being moody. This is an actual disease of the brain. Classically, depression has been described as a deficiency of neurotransmitters, in particular serotonin, dopamine, and norepinephrine. So that's sort of how we always thought about it, because the drugs that treat depression affect these neurotransmitters, increasing their synaptic availability, and as a result, we always thought, well, it's due to some sort of loss of serotonin, dopamine, norepinephrine, or all of the above. Again, because the drugs used to treat depression increase levels of these neurotransmitters in the synapse. However, the effects of drug therapy are over the long term. That is, you don't get an immediate benefit from antidepressants, even though there is an immediate effect on these neurotransmitters. And so this argues for a different process, and it's probably some sort of intracellular process, that is something that is happening within the cell itself. And so by increasing the availability of those neurotransmitters, we're having an effect on how the neuron functions overall. And so it's probably that these are having a longer-term alteration in the functioning of those neurons rather than just simply an increase in the amount of neurotransmitter. We'll talk some more about how that might work later, but to give you a preview, the attention in the cause of depression is now focused on secondary messenger functions. So things like protecting neurons from damage and promoting and maintaining the health of new neurons. And so what we think depression is caused by is a disruption in neuronal processes, and in fact might be due to, or might be causing, chicken and the egg problem here, premature death of neurons or inhibiting the health and growth of new neurons. And we're going to talk more about this neurogenic theory of depression as we move along, but that's what the current view is what we call the neurogenic theory of depression. Existing neurons are able to repair or remodel themselves, and we know the brain is capable of generating new neurons, what we call neurogenesis. It's very different from the view of the brain when I took introductory psychology some time ago. We now know the brain is constantly creating new neurons, generating new ones, repairing and remodeling neurons, and what we think is happening with depression is this process is disrupted. And so there's a loss of neurotransmitter due to this neurogenesis problem. By increasing the neurotransmitter, we're able to actually help the neurons heal themselves and to generate new ones. As I spoke a moment ago, there is a critical role in depression in the association between stress, depression, and a part of the brain called the hippocampus. And the hippocampus is a part of the brain we talked about previously, which is underneath the temporal lobes and is greatly involved with mood regulation. Well, it's part of the limbic system, which is involved in mood, but it's greatly involved in memory and cognition. And so what we want to think about is, what is this role of stress and how is the hippocampus involved? Well, the hippocampus influences many functions known to be disrupted by depression, such as attention, concentration, and memory. We also know that stress is related to depression. We also know that stress is known to damage the hippocampus. In fact, we know people who undergo extensive periods of stress show reduced volume in the hippocampus itself. Cortisol, which is a major stress hormone we haven't talked much about, is released during times of stress, and it really basically shreds the hippocampus. And so long-term stress, extensive stress, is known to damage the hippocampus, and it's possible that that stress could lead to depression. It's also possible that depression is a type of stressor that results in decreased hippocampal volume. In fact, we know that the longer someone remains untreated in their depression, the lower their hippocampal volume can be. So that obviously is something that needs to be treated, something that needs to be addressed in order to stop that loss of hippocampal volume. So we now think of depression as a neurodegenerative disorder. That is, the brain is degenerating as a result of this disease. And I think it's really important that we understand it as a disease, not just a mental disorder, because it is a neurodegenerative disease. Several factors are associated with neuronal repair and neurogenesis, such as antidepressant drugs, light therapy, and electroconvulsive therapy. All of these are used to treat depression. And so we know that having adequate amounts of light and vitamin D is associated with neuronal repair and neurogenesis. We know that antidepressant drugs are involved in these factors, and this seems to be the reason why electroconvulsive therapy has been a viable treatment for depression. It's not used all that often, but it is a treatment of last resort. We're not going to talk much about it because this class is focusing on pharmacological treatments, but there are people who have been greatly helped by electroconvulsive therapy. And if you're really interested in reading more about it, Carrie Fisher and played Princess Leia in the Star Wars movies, has two great books, one called Wishful Drinking, the other called Shockaholic, in which she talks about her experience with electroconvulsive therapy and how it actually helped her. So antidepressants affect secondary messengers such as cyclic AMP response element binding protein, or CREB, which then activates brain-derived neurotrophic factor, which is BDNF. These two substances are important for our understanding of treating depression and thinking about long-term different treatments for depression aside from the ones we have now. So the CREB, or cyclic AMP response element binding protein, is an important precomponent that activates BDNF, or brain-derived neurotrophic factor. And neurotrophic means neuronal growth. And so when we want to think about how to treat depression, how to treat brain disease and disorder, increasing BDNF is a way in which we can increase neurogenesis. And so it's possible things like antidepressants might also be useful for treating things like brain damage, minor head trauma, that sort of thing. So it's important. It's an important area of research. Lots of work going on in this area. It's a very exciting area to think about. So both PrEP and BDNF are associated with neurogenesis in the hippocampus. And so when we affect these substances, we're helping to grow new neurons in the hippocampus, which is, of course, responsible for all of these important cognitive functions and probably is associated with the pathophysiology of depression. So when we start thinking about how drugs are affecting depression, we're probably having an effect on these systems in addition to the neurotransmitters that we're going to talk about. So let's next turn to take a brief overview of how antidepressant drugs have developed over time. The first generation of antidepressants were tricyclics. The name refers to the structure of the chemical, not their function. Everything else refers to the function. The tricyclics simply have to do with the three-circle chemical structure. They block presynaptic transporter proteins of various neurotransmitters, tend to be things like dopamine, serotonin, and norepinephrine. So these are the earliest antidepressants. Now we're going to talk about them and some of their issues later on, but the tricyclics were the first type of antidepressant. The monoamine oxidase inhibitors were the second of the first type of generation antidepressants, and the MAOIs are involved in inhibiting monoamine oxidase, which breaks down neurotransmitters in the synapse. So remember when we talked about neurotransmission, the way neurotransmission is stopped is by reuptake into the presynaptic neuron or by breaking down of neurotransmitters in the synapse through enzymes like monoamine oxidase. We're going to talk about those again in a later lecture. The next generation, or what we call the atypical antidepressants, are modifications of tricyclics, but with fewer side effects. And we're going to talk about a few of these. And there are some sort of special circumstance antidepressants that fit more with the tricyclics because they're kind of like their structure but have different effects. And then finally, we have the selective serotonin reuptake inhibitors and what we call dual action reuptake inhibitors, which also block the reuptake of norepinephrine or dopamine. So we're going to talk a lot about those, and then we're also going to turn and talk about some newer and alternative treatments for depression. So what do we use antidepressants for? Well, obviously mood disorders like major depression, the depressive phase of bipolar disorder, depressive symptoms associated with other psychiatric conditions, cyclopenia, dysthymia. There are other mood disorders in which antidepressant therapy might be appropriate. Alzheimer's dementia with depression, vascular dementia with depression, which is basically when people have had strokes and end up with loss of functioning. Parkinson's with depression. Postpartum depression, now caution, of course, is warranted in treating nursing mothers with antidepressants. Want to make sure that whatever we're treating with is not going to be expressed in milk and not going to be adversely affecting an infant. Adjustment disorder with depressed mood. And then finally, of course, bereavement. And there's some controversy as the DSM-5 has taken bereavement out of the treatment for depression, but there is belief that if you treat that bereavement period after a loss with antidepressants, it's less likely to have long-term implications. Again, trying to stem off that neural loss in the hippocampus. There are other psychiatric or medical conditions that antidepressants might be used for, including sleep disorders, anxiety disorders, eating disorders, attention deficit hyperactivity disorder, substance-related disorders, certain paraphilias. We're not going to get into those. Pain syndromes we will talk quite a bit about, because certainly some of the tricyclics are appropriate for treating pain, as are some of the drugs for treating bipolar disorder we're going to talk about. Some GI conditions, including irritable bowel syndrome, can be treated by antidepressant therapy. And finally, premature ejaculation can actually be treated by antidepressant therapy, as we're going to talk about with SSRIs. One of the side effects of SSRIs is men oftentimes have a difficult time achieving orgasm, and so these can be helpful in staving off that. So, in terms of the prognosis of general antidepressant treatment, obviously we're going to diagnose based on mood symptoms, vegetative symptoms, cognitive symptoms. So when we talk about research in this area, we're trying to assess these things. Characteristics of treatment of depression include recovery or remission, and of course relapse or recurrence. And so the goal of depression treatment is to move people into recovery or remission and to keep them out of relapse or recurrence. So it's important that you understand when we talk about these kinds of effects. So in our top graph, we have somebody who is depressed, reaches remission and stays in recovery. In our bottom graph, we have somebody who relapses fairly quickly, or a year or two later has a recurrence of their depression. And so we obviously want to try to maintain people and keep them from relapsing or recurring into a depressive episode. So the prognosis with medication, about 67% of most patients will respond within 8 weeks. This is a long-term process. Antidepressants take some time, so it's about 8 to 12 weeks before you want to think about switching to something else. Now, unfortunately, about 33% are going to respond to placebo, but which is, I guess, okay. They're going to get better too. So if responders are switched to placebo, 50% will relapse in 1 year. So relapse is obviously a huge problem with placebo. So placebo is not as good as drugs. Even if responders are not switched to placebo, about 15% of them will relapse. So these drugs aren't a panacea, but they are important for helping get treatment. So about 67% of people will respond. If they're not switched, about 15% of those will relapse after a year. Again, depression tends to be more common in women, tends to peak between 20 and 40. Of course, family history is an important part of understanding depression. There's about a 5 to 11% lifetime prevalence of depression, a high rate of recurrence, and a high suicide rate if untreated. So it's important to understand the overall picture of a patient when getting treated. Certainly a family history of depression is going to lean us more towards treating depression with an antidepressant. Our treatment options, of course, include medication and psychotherapy, particularly cognitive or interpersonal therapy, oftentimes in combination with medication, are an important way to go. Oftentimes people will engage in exercise. There are lots of things you can use to try to treat depression. Certainly, people who are severely depressed are probably going to need medicated or psychotherapy or both. Electroconvulsive therapy is reserved for people who do not respond to any of these other treatment options. It's a treatment of last resort, but it can save people from very deep depression. When it comes to antidepressant treatment, only about 20 to 40% of people reach a full recovery. We're trying to get better, but the medications we have available aren't perfect, and there are no reliable response predictors, although there are some genetic tests to try to help determine which antidepressant might work better. We're not going to get into the great detail on that, but it's important to understand that these drugs don't work for everyone, and so we have to oftentimes try different drugs and try different strategies. Well, that's a very brief introduction to antidepressant therapy. We're going to next turn to talk about the specific classes of drugs and what it is